One second, I'm just sorry for that glitch. Actually, a prompt came. So now this is the Goldman applanation tonometer, the pictorial depiction where there is a biprism which touches the surface of the cornea, and this biprism has got a reading of 0 to 180 degrees. Again, when it touches the corneal surface, we start changing the knob position, that is starting from the reading of 1, and we multiply it into 10, and it gives us the intraocular pressure recording. The advantages is that this is a reference standard for all the intraocular pressure measurements and is very reliable with little maintenance. The most important thing is that it is easily influenced by the external pressure. So the clinical pearl, which I would like to again convey to my juniors, that make the patient always comfortable whenever you are performing an applanation tonometer. Because if the patient is going to squeeze the eyes, definitely the IOP is going to be changed and it is going to be variable, and you might overestimate the IOP value. So how are we going to do that? We are going to instruct the patient and explain the patient that actually what are we going to do and why it is required. Because the amount of technical maneuvering which is needed from our side, it cannot be completed without the patient cooperation also. How do we do that? We anesthetize the surface from the temporal side. The blue filter is used, and this is how we get the Myers. In the top picture, we can see the exact Myers touching the inner portion of the rings. This is the Meyer we get. And again, coming back to, if we know the sources of error, that is technique related, either we should not be pushing it too much. The Meyer should be exactly the semicircles what we get. They should be of exact size. Like say, suppose in the left top picture, if we see that if the Meyer is of a bigger size, we need to, the upper Meyer, we need to move the tonometer up. Similarly, we need to move the tonometer down. The centermost portion again is the exact and the accurate Meyer. This is how the Meyer should be once we are recording the intraocular pressure. Instrument related source of error, we all know that's calibration, which is required time to time, because the literature says that the significant number of instruments, they had clinically unacceptable calibration errors, which may lead to error in the recording of the pressure, where each and every millimeter counts. We all know, and we have seen that. Especially when we talk about the corneal thickness, we know that the increased thickness overestimates intraocular pressure when we are taking it by the means of GAT. Especially the exception is that when it is because of the epithelial edema, the IOP is definitely going to be artificially low. Thinner cornea can underestimate IOP, and this should be kept in mind, because when we are treating the NTG and the ocular hypertensive patients, we need to keep the pachymetry values in our mind. The corneal thickness, the post-laser refractive surgery is definitely the better way for them, is I'm going to deal it in the next slide. So it is advisable if we are having the DCT, definitely we can go for that. Else, Goldman applanation tonometry can be used for the peripheral cornea. So the clinical pearl, which I would like to share here for this GAT, would be the irregular corneas interferes with the accuracy of IOP measurements, and the various other means through which we can measure the IOP in those particular conditions. So disinfection is by running water and various other means, all given in the books. That's sodium hypochlorite and going up to the hydrogen peroxide. This handheld Goldman to the most important part of a glaucoma clinic, that is Magay mark tonometer, out of which the tono pen is the modified Magay mark tonometer, where a sensor is there and which is covered by the sleeve, and this records and electrically transduces the pressures, which is again processed by the microprocessor inside this, and it gives this kind of reading. Here we can see in the bottom picture that it gives within the acceptable range of 5 to 20. That is it is how the pressure is going to be recorded, and calibration, it gives the good and the bad value. Again, one more drawback of this is that it overestimates the low IOP and underestimates the higher IOP. Again, coming to the pneumatic tonometer, which is a modified version of this Magay mark only, but only the difference is that the gas pressure is used instead of electronically controlled plunger. NCT, we all know that no anesthesia is required and no damage to corneal epithelium can be done. Maklakoff, it's not very much used clinically. ProView, that's really very important, because this you can give your patient if they are they need to do the home tonometry, though it's not very reliable, but yes, to get some assessment, especially in the cases of keratoprosthesis where we cannot measure the intraocular pressure. This ProView can be helpful for us, which has a scale reading, and the patient appreciates a phosphene, and looking via these phosphene, by the time the scale moves, and the pressure can be recorded. Dynamic contour tonometry measures the surface contour matching, and the most important part of this tonometry is that it gives the ocular pulse amplitude, which gives the indirect perfusion of the choroidal, the indirect measurements of the blood flow, ocular blood flow, and this is helpful in the cases of normal tension glaucoma. And the clinical pearl would be that it is especially useful in classic patients and the OPA for NTG patients, where it needs to be, where it is on the lower side. Now coming to the ocular response analyzer, which records two applanation events, the cornea moving inwards and the cornea moving outwards, the average of which is the intraocular pressure, and the difference is the corneal hysteresis, though not used very much clinically. Now, this is I should say, this is becoming a very popular tonometry these days, every day, where in the clinics, and definitely in a busy OPD, it can be used, but never we can replace the Goldman applanation tonometry by rebound tonometry, though it is useful for the children and for the patients who are not able to cooperate, faster technique. Basically, this works on the principle of deacceleration. The higher the IOP, the faster the probe deaccelerate, and shorter is the contact time. So now, while concluding, I should like to highlight that what are the special clinical conditions where certain specific type of tonometers are preferred, like in irregular corneas, the pneumatic tonometer, the soft contact lenses, pneumatic and tonopen can be used, and in gas-filled eyes, the Goldman tonometer can be used preferably. Concluding, I would say that increased accuracy of IOP estimation can be achieved by proper instrumentation, correct technique, attention to ocular factors, like rigidity, CCT and all, and influencing the IOP estimation. Thank you very much for your patience hearing.
Thank you so much, Dr. Shweta. That was indeed a wonderful presentation and an elaborate one also.
Thank you.
I just had a question with you that suppose you are using so many tonometers, do you feel that Schwartz tonometer still has the role?
No, ma'am, because Schwartz, the agreement between Schwartz and this GAT is not very much agreeable. The kappa factor is low. So definitely we cannot use, but yes, for the beginners, or I should say in the first year, just to get the knack of the thing, they can doing it, but we should not rely, and we cannot treat the patients depending on the Schwartz tonometry. Whereas I said that each and every millimeter counts, and we cannot correlate with the pachymetry as well, because the nomograms and everything is not, I should say, calibrated with the pachymetry value as the GAT has been done. So better in the glaucoma clinic, if it is advisable, if we can go for applanation tonometry.
Thank you so much, Dr. Shweta.